ninth webinar organized by the Latin American Endocrinology Federation, FELAEN. Today's event is titled Obesity, Medical Treatment or Surgical Treatment. It will be in charge of Dr. Ela Manrique from Peru and Hernando Forero from Colombia. I'm Dr. John Jairo Duque Osman. Greetings from Armenia, Quindío, Colombia. I'm an endocrinologist, member of the Colombian Association of Endocrinology, Diabetes and Metabolism, coordinator of the Thematic Committee on Obesity and Nutrition, member of FELAEN, faculty of the Program of Medicine of the Quindío University in Armenia, Quindío. I will mention some relevant aspects of the session. First of all, we will keep our cameras and microphones off. We have, as you well know, simultaneous interpretation from Spanish to English available on the icon of the globe so that you can have access to the audio of the language of your preference. The webinar will be reproduced live on our YouTube channel. It will also be at demand both on this channel as well as on our webpage, Facebook, and in the Global Education channel of the International Society of Endocrinology, who endorses all our events. After the second conference, we will have a questions and answer session, both those that the participants have sent beforehand during their registration, as well as those you write on the chat tool during the conference. It is located on the lower part of your screen. Your questions can be either in Spanish or English. We will be issuing certificates for continuous attendance that our team will verify at the end of the event. Next, I will be introducing the first speaker, and Dr. Imperia from Venezuela will be presenting the second speaker. I am very pleased to present a very good friend from Peru. He's an endocrinologist, and for many years, we've had a great friendship. We have met in great events. His name is Helard Manrique. He is member of the Hormonal Health Committee of the American Society of Endocrinology, member of the Global Council of the European Association of Diabetes. He is a coordinator of the endocrinology service of the Delgado Clinic. He is the medical director of the Research Center in Diabetes, Obesity and Nutrition, and thesis advisor from the Peruvian University Cayetano Heredia, and he is the former president of the Peruvian Society of Endocrinology. I yield him the floor so that he begins his conference. Dr. Helard, welcome. I would like to thank the Latin American Federation of Endocrinology and Dr. Jairo to be able to talk about the medical therapy in obesity. I have some 20 minutes to speak with you, and I would like to begin this presentation with a topic and this title, which I think is very important. Can medical therapy displace bariatric therapy? I think that 10, 15 years ago, we couldn't think that way. We will discuss it, and I think it's important to share my conflicts of interest as you see here. But why do we talk about obesity today? Because it is really the root cause of all cardiometabolic problems. You will sow what you reap. If you sow overweight and obesity and a poor nutrition, you will have visceral fat accumulated over time, ectopic fat, low-grade inflammation that's initiated by inflammatory cytokines in all the tissues, and this will lead to endothelial dysfunction and insulin resistance, and it will allow low-grade inflammation. This will lead to dyslipidemia, hypertension, diabetes, and heart disease. But this is the end point. but we will be focusing on managing obesity and overweight, which is the root of the problem. So why do we have obesity? Everybody asks, well, doctors, do I have bad habits, bad genes? My food is really bad. My habits are very bad. I have an altered personality, or I have a toxic environment, or simply I just have bad luck. The answer is not a single one. There are multiple answers, but we as physicians who see obesity every day, it's a big challenge to see the patient in the outpatient clinic and manage overweight and obesity. We have the impact. We know there's an impact on weight reduction because when we reduce 5%, 10 or 15% of body weight, we decrease the risk of diabetes, hypertension, hyperlipidemia, fatty liver, sleep apnea, arthritis, urinary incontinence, or gastroesophageal reflux. So we know that losing weight implies a mechanical inflammatory cardiometabolic benefit. In these conditions, as obesity experts, we try to manage the overweight in a general condition. But there is a very important point here. Obesity is not only one thing. Individuals are different in their anthropometric metabolic variables and have different phenotypes and behaviors. Therefore, obesities are totally different. This makes us train ourselves in managing obesity. And the algorithm is not only including lifestyle changes. Lifestyle changes have an impact on weight loss, but we also use anti-obesity medications with increased benefit in weight loss. In that condition, when you have adherence to a drug and a lifestyle management, we have a goal. The patient has to lose 5, 10, or 50% of the weight. If they don't reach the goal, we'll have to recur to bariatric surgery. In these conditions, we have to see the effectiveness of these weight loss strategies. If we talk about lifestyle, we have between 5, 7% of success in weight loss when we do extreme weight loss diets with very low calorie diets, 6 to 10%. When we use drugs, this will vary depending on the patient, on the type of drug. It can be between 10 and 50% of body weight loss. But when we talk about bariatric surgery, weight loss goes between 7 to 23%, depending if it's a gastric band or a sleeve, it goes up to 28%, and gastric bypass up to 38% success in weight loss. We have seen that the number of bariatric surgeries has increased around the world. What we see is that there is a perception that weight loss is not very easy. And today we really know that bariatric surgery is a way of treating obesity. But how can we manage obesity? We as endocrinologists have a strategy. It's multidisciplinary management with a nutritionist or a sports physician or a psychologist, psychiatrist, a bariatric surgeon as part of the obesity management team. What is the goal? That the patient loses weight over time. For that, we need to use strategies. A big problem is follow-up and time. Many of our patients lose weight, but they regain weight over time. Why do they regain weight? Here are some reviews. Patients that have been uh, gastrectomatized or they have a good amount of weight loss and they regain 5 to 7% at 2 years or 75% at 6 years. Why does this happen? The stomach dilates, there's an increase of GLP-1 levels and an increase in ghrelin levels. This increases appetite, or really the patient did not change their behaviors. I think this is interesting because at the end, caloric intake increases in these patients with obesity and they regain weight and they do not exercise. They start having psychosocial stress, and this dietary dysregulation allows patients to regain weight. In these conditions, this is known as eating dysregulation. The important trigger is associated with impaired appetite control perception and satiety signals are lost over time. So what happens with our patient who managed to lose weight? Probably he did not have an adequate follow-up. He went back to the obesogenic environment. He's working in the same place. He has the same family. He has the same everyday environment, and that conditioned him to have a life stress. Once again, he had an emotional stress, and the hungry brain was activated. And a critical point is that he never learned to eat, and this generates that the patient regains weight. This is important. How does this happen? Because patients many times post-surgery do not have a follow-up. So going back to the beginning, after a large weight loss, patients regain weight. So
Entonces,
I always
siempre
ask
yo
my
planteo a los
residents and the
residentes
people
y a
that
las
rotate
doctoras que
with
hablan
us,
con nosotros,
what is the
cuál es el
appropriate
esquema
weight
de carga y
management
entrenamiento de
plan?
peso. Uno de
Well,
los
the first
primeros
thing
es
is a
una
good clinical
nutricionista
history, a
que
food
analiza tu
anamnesis to see
alimentaria
the energy
y nos recomienda tu
requirements
energía que
they
necesitas
need,
con
an
una repetición
adequate
interval
nutritional prescription,
adecuada
and a
y un mantenimiento
pharmacological prescription,
farmacológico durante
motivation,
un
and follow
seguimiento
up
a lo
over
largo del
time
año.
because
Porque
obesity is
obesity
a
en general
chronic
son adultos
disease
que
that
necesitan
needs
motivación
permanent
permanente.
motivation.
Pero
But there is a
la parte
nutritional
funcional no es
strategy. It's
exactamente
not today's
eso, no
topic,
es
but if you don't
exactamente
manage a
funcional, por
nutritional
más que demos el
strategy,
mejor
it
fármaco, no
doesn't
tiene
matter the
impacto en la
best
pérdida
drug
de
you
peso.
give, it won't have an
Los
impact on
medicamentos
weight
que
loss.
tenemos
What are
en
the
Perú
drugs we have in
actualmente
Peru?
tenemos, miren
We have
esto, tenemos
phentermine,
interferón, que es la
phentermine
inhibida por
topiramate,
separado, la
naltrexone,
glucosa y la glutida.
bupropion,
Esos
and
medicamentos actúan por
liraglutide.
enlace
These drugs
receptor
act on
que
appetite
actúan dentro del
reduction
intestino,
at the level of the
inhibiendo la
gut. They
absorción de
inhibit the
proteínas,
absorption of
lipasa,
lipase and
perectina, la
allowing the
absorción de grasas,
non-absorption
esa
of
lógica.
fat that would be
Pero obviamente
orlistat.
el impacto en la
But
pérdida de
look at the
peso
impact on
son
weight loss.
10%
5 to
fentermina sola,
10%
fentermina topiramate
ferritamine
sola,
alone, or with
15%, porque
topiramate
gluconate,
5
bupropion
to
5 a
50%,
10%
naltrexone,
y la glutide
bupropion
5 a
5 to
10%,
10%,
lorvistatin a
liraglutide
5%.
5 10%,
¿Recuerdan
orlistat
los
3 to 5%.
resultados de la cirugía bariátrica que hablaba
Remember the
anteriormente?
results of
Miren,
bariatric
de un
surgery that
45%
talked
hasta
about 10, 15,
28% de pérdida de peso
25, up to
espectacular. Creo
28% of
que
weight
hasta ahí
loss.
estamos
I
perdiendo
think clinicians are
los
losing here
cínicos,
because these
porque
drugs
realmente estos
have an
fármacos tienen
impact
un
on
impacto en
weight
la pérdida de
loss,
peso,
but it
pero
is
se dice
between
que el 15%
15%
como máximo
maximum
en
on
la pérdida
weight
de
loss.
peso.
But when
Pero
the
cuando nos aparecen
GLP-1s
los
appeared,
GLP-1, cambia la
story
historia.
changed.
Análogos de
L
GLP,
GLP-1
estos dos
analogs,
son
not only
idénticos,
liraglutide, which is the one we have in
empezamos a
Peru,
ver en
there
otros
are
fármacos
other
que son los
long-acting
SARM,
drugs, and
y
we
que
begin to understand that
empezamos
these
a
are
entender
drugs
que
that
son medicamentos
act
que actúan
at a
a
systemic
nivel
level, at the
sistémico,
level of the
a nivel de la
pancreatic
célula
beta
beta
cell,
pancreática,
improving
disminuyendo la
insulin
secreción de
secretion,
insulina, disminuyendo la
decreasing
secreción de
glucagon
glucagón,
secretion,
disminuyendo
decreasing
la
the
producción de
hepatic
factores
production of
glucósicos a
glucose
nivel
in
cerebral, grasa
the
cerebral, a
brain,
nivel de
providing
irradiación, a
satiety
nivel
and
cardiovascular,
decreasing
disminuye
energy
la presión
intake at the
sanguínea,
cardiovascular level.
aumenta el
They
procesamiento
decrease
grasígeno
blood
indirectamente y
pressure,
verá
they
que aumenta
decrease
ligeramente
gastric
la frecuencia
emptying,
cardíaca.
and they
Pero no
slightly
solamente es eso,
increase heart
existen
rate.
receptores de
But
GLP-1
there
en las
are
fibras
also
musculares
GLP-1
listos
receptors in
en
the
zonas que
muscle
ayudan a
cells,
mejor
allowing a
regulación
better
de la
remodeling
acidez
of the
sostenible de la
arteries, and
urina,
this allows a decrease
previamente
in
una
blood
disminución de la
pressure,
presión arterial,
the release and
permite la
increase
liberación y el
in
incremento de
nitric
oxígeno,
oxide, a
predispone a
greater
mayor vasodilatación
vasodilation, and in the
y a nivel
kidney,
renal
they have a
permite un efecto
natriuretic effect.
natriurético, lo
This
cual permite una
allows
mejoría de
an
la
improvement
presión arterial.
in blood pressure. These
Estas
conditions
condiciones
allow us to
permiten
evaluate
evaluar
that they
que
not
tienen
only
no
have an
solamente un
effect
efecto en
on
el
the problem
problema
of
del
weight
control de
loss
peso,
and
ni solamente
diabetes,
en el control de la
they also
diabetes,
have an
también tiene
effect
un efecto en
on
el control de la presión
blood pressure
arterial, un
control,
efecto a
on
nivel
the
del sistema nervioso
sympathetic
simpático,
nervous system,
mejorando la
improving the
hiperactividad
sympathetic
simpática, también
hyperactivity,
mejorando la disminución
improving
de los
the
niveles de
decrease
ejercicio
in
en la voz
angiotensin
y
2
mejorando
levels,
la difusión
improving
endotelial y mejorando
endothelial
la excreción
dysfunction, and
renal de
improving
sodio
renal
y
sodium
disminuye el apetito
excretion.
inmediato.
And it has a
Estos son
diuretic
puntos
effect.
importantes
These
que a
are
veces no los
important
vemos en
points
los
that we don't
GLP-1
see in GLP-1s today.
pero volvemos al peso
But
nuevamente,
going back to weight
porque una
again,
vez a la
once
semana
a
se
week
permitido que tu
semaglutide in
nariz esté
overweight
sobrepeso,
adults, we started increasing the impact on the percentage of
pérdida de
weight
peso.
loss,
Ya
not
no
only
solamente
10
es un
to
10 a 15%,
50%.
llegamos a
It's
un 16% de la
16%
pérdida de
weight
peso
loss with
conforme les miren
semaglutide
en
in
este
this
estudio de 68
68-week
semanas.
long study.
Creo
I
que
think that
llegar a
2.4
este punto
milligrams, if you
miligramos,
know, is
ustedes
not
saben que no es muy
easy, but
sencillo,
we really
pero
start to
realmente
have a
empezamos a tener un
major
impacto
impact
interno
on the
importante en el
percentage of weight
porcentaje de la
loss.
pérdida de peso.
But when
Pero cuando aparece
tirzepatide
esta
comes
bajada,
along, it
el
has a
retroceso
weekly
por semanas,
application. We
empezamos a ver
see
que es
it's a
un
different
análogo
analog.
diferente.
Why?
¿Por qué?
It is
Porque es un
designed
análogo
to act
diseñado
on two
que actúa sobre dos
receptors. They
receptores,
have a dual
que tiene un
mechanism
mecanismo dual
on the
sobre el péptido
glucagon-like
parecido
peptide
del
type
glucagón
1
tipo 1
and
y sobre el péptido
glucose-dependent
insulinotrópico dependiente de
insulinotropic
glucosa,
peptide, which
lo
increases
cual
its
incrementa
efficacy
su
in weight
eficacia
loss.
en la pérdida de peso.
If you see, it's a
Luego, esta es una
chimera,
quimera, un
a
péptido chimera
chimeric
que
peptide that allows
permite eso.
action on these two receptors. So what is the impact on weight loss? If
Entonces, si
semaglutide had
semaglutide tenía
16%,
16%,
tirzepatide has three
tercipatide
doses,
tiene tres
5
dosis, la
milligrams,
de
10
5
milligrams,
miligramos, 10
and 50
miligramos y 15
milligrams
miligramos.
presentation.
Y vean
And at
ustedes,
72
a las
weeks of the
72
study
semanas
with
vestido con
tirzepatide, weight
tercipatide,
loss
la
is
pérdida de
up
peso
to
llega hasta el
22%.
22%.
This is very
Esto es
interesting.
muy
How
interesante.
do we pass from
Pasamos
percentages
de
of
porcentajes de
15%,
15% a
16%, and
16% y
currently with
actualmente con
tirzepatide
tercipatide
22%
22% de
weight
pérdida de
loss? I
peso.
think it's very
Creo que
important
es
to
muy
remember
importante
that these
recordar
patients
que estos
have
pacientes
an
pues tienen
important
una pérdida
weight
de
loss
peso muy
because of
importante
the dual
por
inhibition of
inhibición
these two
dual de estos dos
receptors.
receptores. Y
When we see
cuando
phase
vemos
3
estudios de
studies
fase
such as
3
this
como
one,
este estudio, como es
they
que
act
actúan a través
through
de el agonismo de las dos
agonism against
receptores, ya
three
no solamente
receptors, not only
de la glutamina,
glucose-dependent insulin-tropic
sino la
polypeptide,
ingrediente
but
glucosa,
GLP-1 and
y
also
tenemos
the
el
glucagon
receptor de
receptor.
glucagón,
This is
que
a
es un
triple peptide
triple
that allows
que
an
permite
impact
un
on weight
impacto
loss.
en la pérdida de peso.
And
y
you can
vean
see the
ustedes el
result. The
resultado. El
total
cambio
body
del peso
weight
corporal
change was
total fue
24% of body
24% de
weight.
peso corporal.
So
Esto
this
era pues
was
increíble.
incredible.
Ustedes
We're
hablábamos
talking
de los
about the
impactos en la
impact of
pérdida de
weight
peso con la
loss
cirugía
with
bariátrica,
bariatric
que
surgery
va
that
del
reaches
7% para arriba.
28%
Así
average with
como aquí en
medical
América
therapy.
se hace
This is much
pues
more
mucho más
important, very
importante, muy
close to
cerca de la
bariatric
cirugía
surgery.
bariátrica.
And when we see
Y cuando
patients
vemos
that
en pacientes
had
que
a
tenían
BMI
IMC
greater than
mayor de
35,
35,
it's up to
llega a tener hasta
26% weight
26%
loss.
de pérdida de peso.
I think this is
Y creo que
very
esto es
interesting
muy
because
interesante
almost
porque
80% of
casi
the
el
patients
80%
lose
de los
more than
pacientes
20%
pierden
of their
más
body
del
weight.
20% del peso corporal.
And this is something we observe over time, that a medical treatment has such an impact on weight loss. Retatrutide has not been approved yet, but probably in the next few years it will be approved. So if we start seeing how semaglutide, the average
La
weight
pérdida de
loss
peso
is
promedio es
14.9%
14.9%
and
y el
32%
promedio
drop
científico
more
basado
than
en 20%
20%
del
weight
peso,
tirzepatide,
el cepatide,
the
el
average weight
20%
loss
del
is
paciente baja el índice de peso
20%
corporal
and
y
57% lost more than
57% baja el índice
20%
de
of
masa
weight.
corporal grasa
With
y el
retatrutide, the
54%
average weight loss is
del peso líquido.
24%, 86% lost more than 20%, and 100% lost more than 5% of weight. So nowadays, medical therapies are becoming very effective in weight loss. How safe are they? Well, the adverse events are really associated to their digestive effects, as all GLP-1 analogs, nausea, vomiting, reflux, that are treated symptomatically and titrating the respective dose. Then we start to see the evolution of the hunger peptides. This brings about a great responsibility, the knowledge of these drugs, and we start to see that single GLP-1 analogs went to dual combinations, and today we will probably have triple combinations combined with GLP-1 glucagon agonist receptors, glucose-dependent insulin-tropic peptides. But not only do we have these type of drugs, semaglutide also has trials related to other receptor agonists that are also appetite controllers, which is human amylin, that is a non-selective agonist and that also contributes to weight loss. Phase 2 trials with amylin, cagrilintide, which is an amylin, has an average weight loss of 10.8% of body weight at 26 weeks. You can see it's very similar to the other older drugs we have. But let's see the impact when I add semaglutide with carlinlintide. Under these conditions, we observe that the combination is going to have this effect, as you see
Vean
here.
ustedes
The
aquí,
combination
la
has a weight
combinación tiene
loss
una pérdida de peso
above
por encima del
15% at 20
15% a
weeks,
las 20 semanas.
almost
Estuvo del
18,
18 al
19%.
19%. Entonces,
So we're having more combinations in the future, not only dual therapies that we know. So we're passing from monotherapy to dual therapy, and probably we will have a triple therapy, and that it's getting closer and closer to bariatric surgery. So one might wonder, is it going to be necessary to do that many bariatric surgeries? So we're transforming the treatment of obesity with the advent of treatment with multiple receptors that condition the control of hunger and appetite. You must remember that these receptors are not only in the appetite center, they also act on the pancreas, adipose tissue, bone tissue, stomach, brain, heart, liver. These are systemic receptors. And when we start managing these drugs, we really need to be aware of the adverse events. But we will observe how they will have an impact on body weight loss with dual and triple therapies. Considering this, what is coming in the next few years are triple therapies. They are associated precisely with the triple combination. I believe that all of us in Peru have liraglutide. We have dulaglutide. We still don't have semaglutide. They import them, and they have an impact on weight loss. But they have no, we have no doubt that when we have double or triple therapies, the impact is greater. So that makes medicine personalized. Sometimes we try to treat signs and symptoms, but in obesity, oftentimes they're not signs and symptoms. We treat generally from the point of view of weight, but we need to treat the patient's behavior. And it's very important to personalize treatment. We need changes in eating behavior. And I think the drugs are the necessary tool to change these eating behaviors. I think it's very important associated to nutritional therapy. In conclusion, I think it's very important that today we
Hoy
have
día
powerful
tenemos
tools
herramientas muy
for
poderosas
losing
para
weight
perder
from a
peso desde el
medical
punto de
point
vista
of view.
médico
It's very
y
important to
es muy
understand
importante
that
entender
weight
que hay que
loss has to
mantener
be
la pérdida de
maintained
peso a
over
lo largo
time.
del tiempo.
Always have to
Siempre
think
hay que
that
pensar que
weight
la ganancia de
regain
peso
is
es
possible.
posible. Por
In
ejemplo,
bariatric
después de una cirugía
surgery,
bariátrica, como
at
vieron,
6 years,
a los 6 años el
70% of
70%
patients
reganan
regain
peso.
weight.
Igual que después
Also,
en tratamientos
this
médicos.
applies to
Por
medical
lo
treatment.
tanto, acá
Therefore, we
necesitamos
need a
un trabajo
multidisciplinary work
multidisciplinario
between
entre el
the
grupo
chemical or
químico y
pharmacological
quirúrgico.
and surgical
Y
group.
creo que es muy
I think it's very
importante
important to associate
asociar que la
prevention and
prevención
management
estrategias de
strategies so
manejo
that
para
the
que el
patient
paciente
does
no
not
regane
regain
peso.
weight.
Y esto
And this is
importa en el
important in the
seguimiento de
follow-up
los
of patients
pacientes
after
después de las
therapy.
terapias.
I have patients
Tengo
that lose
pacientes que pierden
20% of their
20% de
weight,
peso,
25%,
25% y
and then
muchas
they
veces
disappear one
desaparecen
or
un
two
año, 2
years
años
and
y
they
nuevamente
regain weight.
reganan peso.
It is very
Es
important
muy
that they
importante
know
que
they
ellos
need to
sepan que
have
tienen que tener un
a
seguimiento a largo
long-term
plazo
follow-up
y
and
que
that they should
consideren que la
consider
obesidad
obesity
será
as a
crónica
lifelong
o
chronic
por vida.
disease.
Y creo que
I
en
think that
evidencia
current
actual
evidence
que
we
hemos
have
evaluado hoy día
evaluated
nos sugiere
suggests
que la
that
farmacoterapia
pharmacotherapy has as
tiene
much
tanto
impact on
impacto en la
weight
pérdida de
loss
peso y tanta
and as much
eficacia los nuevos
efficacy as a
fármacos
new
que la
drug.
cirugía. Y creo que hoy día
I
las
think that
combinaciones de
drug
fármacos también
combinations
tienen
have an
impacto
impact in
y que los pacientes
patients.
van
They're
a
going
perder
to
más
lose more
peso
weight
a
in
lo largo del
time.
tiempo.
Probably the conditions
Probablemente
and
las
the
condiciones y la
discussion
discusión que
we will
vamos a
have
tener
at
al
the end
final de
of
la charla son
these
el
conferences will
impacto
be
que
the
tiene
impact on the
en lo que
metabolic
es el
benefit,
beneficio
but
metabólico,
also
pero
how
también qué
much is the
tanto es el
cost of
costo de
these
estos
drugs. And I
fármacos.
think
Y
we can
creo que
discuss
eso lo
that
podemos
because
discutir
the
porque
medical
el
benefit is
beneficio médico está
established. I would
establecido.
like to thank
Quiero
once
agradecer
again the Latin
nuevamente a
American
la
Federation of
Federación Latinoamericana de
Endocrinology
Endocrinología por la invitación
for
a
discussing
para
this
conversar de este
important
tema,
topic.
que creo
It's
que es de
vitally
vital
important
importancia
for
para todos los
residents,
médicos
and I
residentes
think that the
y creo que el
training in
entrenamiento de la
obesity
obesidad pues
is
es
important in
importante
all
en toda residencia
residency
de
of
endocrinología.
endocrinology. Thank you.
Muchas gracias.
Good morning
Buenos
and
días,
welcome. It's a pleasure
bienvenidos.
to
Es
greet
un
you
gusto
from
saludarles
Venezuela.
desde
I'm
Venezuela. Yo
Dr.
soy la doctora
Imperia
Helard
Bajrovich,
Berkovich,
endocrinologist,
endocrinólogo
internist,
internacional
member of
y
the
miembro de
board of
la
director of FELOIN and
ICE
ICE,
de
which is
ICE,
the
que es la
International
Asociación
Society of
Internacional de
Endocrinology.
Endocrinología.
I was a
He sido
former president of
especialista
the Latin American
en
Obesity
Venezuela
Society
y
and
diversas
different
sociedades
Venezuelan societies of
venezolanas de
endocrinology
endocrinología
and
y la de
obesity.
ICE.
I have the honor
Tengo el
and the
honor
pleasure
y
to
el agrado de
introduce our second
presentarles a nuestro
speaker,
segundo
Dr.
conferenciante,
Hernando
el
Javier
doctor Hernando
Forero,
Javier Forero.
is a
Él es
surgeon
médico
graduated
cirujano
from
egresado de
the
la
University
Universidad
of
de
Quindío,
Quindío,
specialist in general
especialista en
surgery
cirugía general de
from the San
indicación de la
Martin
ciudad de San
University
Martín
and in
y en
laparoscopic
cirugía
advanced
laparoscópica
surgery and
avanzada de
bariatric
la
surgery
carrera de la
from the
Universidad
SES
CES
University
de
in Medellin,
Medellín.
member of
Miembro de la
the
Sociedad
Bariatric
Internacional de Cirugía
Society of
Bariátrica,
Colombia,
cirujano del
surgeon of the
Centro de
bariatric
Acidez
surgery
de
and
Enfermedades Digestivas,
digestive
ENDO.
diseases endos.
Les
At the
recuerdo
end
que
of
al
this
final de
second
esta segunda
conference, we will
conferencia
have a
habrá una
Q&A
sesión de
session
preguntas y
that we will be
respuestas que
coordinating between
coordinaremos el
Dr.
doctor
Duque and
Duque y
myself.
yo.
Without further
Sin
ado,
más
I yield
preámbulos,
the
le doy la
floor to
palabra
Dr.
al doctor
Forero.
Forero.
Good morning,
Buenos
everyone.
días
I
a
would
todos.
like to
Quiero
thank
agradecer
Dr.
al doctor
Duque for
Duque
this
por esta
invitation to this
invitación a
academic
este evento
event,
académico,
Dr.
a la
Imperia,
doctora
Dr.
Imperia, al doctor
Manrique, and
Manrique y a toda la
all
organización, al doctor
Filain, and
Helard
all the
y a todos los
participants
participantes
that have
para
taken this
unirnos esta
Saturday
jornada
morning
para
for this
estas
academic
reflexiones
session.
académicas. Bueno,
Well, the
el tema
topic that corresponds
el
to me
informe de
is whether
se
bariatric
trataba de
surgery
la
will
sanidad
be
médica
replaced by
basada sobre el
medical
tratamiento
treatment. And I'm
y
going
voy a
to
tratar de
try to clarify this topic,
dilucidar este tema
to
brevemente.
elaborate it
Vamos a
in
hacerlo
several
en
parts.
varias partes.
First, I'm going to
Voy a
show how we
cómo
perform a
hacemos el bypass
gastric
gástrico, las cirugías gastric
bypass. This is
bypass.
the most common
El
surgery we
resultado de la cirugía
perform, bypass and
bariátrica
sleeve.
y
Then we will
posteriormente
talk about the
complementaremos con
results of
cirugía
bariatric
bilateral
surgery,
con cirugía con
and we will compare the results with medical
luego miraremos
treatment. Then we will
la
see
derivación
adjuvant and
de la cirugía
non-adjuvant
bariátrica con los
therapy with the new
procedimientos de una
anti-obesity
obesidad
drugs,
y
and I will
haré unas
finally
conclusiones.
give some conclusions. When
Cuando
Dr.
el
Duque
doctor
invited
Duque me invita a estos
me to
estudios
these
congresos de
endocrinology
endocrinología de medicina interna,
internal medicine congresses, I feel
pues
like the can on the slide,
pero
but
en
it is very
realidad vamos a
important
salir de
to
esta
give
hablando
these
de la obesidad.
conferences, and
Es
I
muy importante
hope
hablar de
I
obesidad
can pull it through. It is very important to talk
interdisciplinariamente,
about
ya
obesity in
que
an
mencionábamos que
interdisciplinary way
el Día
since
Mundial de la
the
Salud
World
espera que en el
uh,
2030
Health
1.1
Organization
billones de personas
believes that
sufran
by
de obesidad y luego
2030,
unos
1.1 billion
2
people will be
billones
obese and
que tengan
2.2 billion will
sobrepeso.
be
Lo que
obese. So
quiere decir que más
approximately
de un
60% of the
75%
world
de la población
population
mundial
will be
tendrá
either
algún
overweight
problema
or
de sobrepeso
obese.
y obesidad.
When we go back in history and talk about metabolic surgery, we find that in 1955, Dr. Friedman talked in a gynecology journal about the results of a decrease or improvement in diabetes mellitus in patients that had undergone a partial gastrectomy for benign disease or for a malignant disease. And in 2004, the father of metabolic surgery, Dr. Buswald, said in one of his congresses that the most striking effect of the bariatric surgery is not weight loss, but remission of type 2 diabetes, a disease that was considered progressive and incurable. So I will show you how we do the procedure. Basically, I would like to show how my team and I do a gastric bypass. You might be used as endocrinologists to see this image in the textbooks, how a bypass is, but you have not seen the laparoscopic reduction we do. We put the trocars and we start cutting the epiplon. Basically, the loop is here. We seek for the trace angle, the fixed loop, which is the fourth portion of the duodenum, and we move it, the loop up. We don't measure it. We simply make sure that the loop of the bowel cup goes in this position where we're going to anastomose the gastric pouch. Then we dissect the greater curvature, this fat pad we find in all patients. We dissect that part of the stomach, and afterwards we try to go to the back part of the stomach, the transcavity of the omentum. We do this through the lesser curvature, as you see in the video. This is the lesser curvature in this part of the stomach, and this device sections and coagulates simultaneously as we advance. We section and we go to the transcavity of the omentum. We're going to enter behind the stomach, look at the dissection, and we staple and we cut on either side, as you see on the video, and then we create this new stomach. What is left is this pouch, this small stomach that remains, and we raise the loop and we anastomose. This loop that we're measuring, 150, it should measure by 2 meters according to the patient's body mass index. After we have the measurement of approximately 1.5 meters, we join it to the biliopancreatic loop, and then we do this anastomosis, which is the jejunum jejunal. We also do it with staplers, linear staples, laparoscopic staples, and we close the enterotomy with conventional sutures. And here we have the roux in Y, and it's done. And then the patient has less gastric capacity and less absorption, because in this 1.5 or 2 meters, that is what they will absorb. And this is the biliopancreatic part, which is a common loop. We close the omentum defect, which is a hole that is left in the middle of the omentum of the intestine that avoids the internal loops. We advance the catheter, a probe, and then we apply the probe through the anastomosis. We apply methylene blue to make sure there is no stenosis, that the bypass is well formed, and that there are no leaks, very important, during the surgery. To finish the procedure, we make some blocks in the abdominal wall to avoid pain, and we leave a little bit of saline solution with lidocaine applied in the diaphragm. We remove the drains, and that is the gastric bypass. It is one of the most common bariatric surgeries performed. In the statistics of 2020, 198,000 bariatric surgeries were done in the US. Most of them were gastric sleeve, and the next one was the common bypass. Adjustable gastric bands are less and less used because of the effects we have had with the band and the non-promising results. The anastomosis gastric bypass is growing, and revisional surgeries are also growing, especially in the conversion from gastric sleeve to gastric bypass, either due to reflux or weight gain, regain. Outside the US, since 2014 and 2018, the frequency of surgeries is more or less repeated. The sleeve gastrectomy is the first. As I told, I do most bypass than gastric sleeve. The results of
Los
bariatric
resultados de la
surgery
cirugía bariátrica,
are
digamos que
very
para
well
que
known
nuestro
by
cerebro
many of
entienda,
you.
la
The
disminución
decrease
del nivel
in
glicémico, la
glycemial
disminución del
levels and blood
glucosamínea,
pressure, the
disminución
decrease
de
in
las enfermedades
cardiac events,
cardíacas, tanto
both
infartos,
heart attacks,
miopatía
heart failure,
cardíaca,
coronary events,
dolor
decrease in
renal, tenemos
cholesterol,
clenbuterol
and
y también
improvement
podría
in
la
sleep
aminoterapia.
apnea. All of
Todos
these
estos
results are not
resultados
only
no son
explained
solamente
by weight
básicamente
loss,
por la pérdida de peso, también
we
por
also do
ejemplo
it
por
through
diferentes
different modalities of
modalidades
hormonal
de
changes.
cambios
In this
hormonales.
article published
En el
this
artículo
year,
publicado este
where
año,
we
en
study the
el artículo
motility
publicado
of
sobre
hormonal
los cambios hormonales, vemos cómo
and
la
the
movilidad
hormonal
esofágica está
changes, we see
disminuida
how esophageal motility is decreased thanks to the fact that you see an increase in the tone of the lower esophageal sphincter, while gastric motility is increased. That is why the patient may have dumping syndrome.
síndrome de dumping, mientras
While the
al lado,
colorectal
al lado
part is not
no
affected,
está tan afectado,
the
el
gastrointestinal
movimiento
movement
espacial
in the
entre el
jejunum
tránsito
is
del tránsito
increased, but
esofágico
the
aumenta y la masa
ileocecal valve
que
delays the
desplaza los
food,
alimentos.
and
Estos
these
alimentos
foods
están
are
en contacto
in
con el
more
ganglio
contact with the
pineal,
terminal
y
ileum.
esta
It
estimula
increases the
las células
stimulation of L
semillas que
cells.
van
It
a
increases the
depositar
production of
leptinas que van a
incretins
determinar
that will
cada
trigger that
cirugía,
each
cada
surgery, as we
cuadro,
see in the chart,
tenga
has
variables. La
variables
creatina
according to the
varía con
hormone.
la
Ghrelin
creatina en
in the
la creatina
bypass is
varía
variable.
según
In
la
the
malla
gastric
gástrica del
sleeve,
músculo.
it
Recuerden
uh,
que nosotros quitamos el fondo gástrico
decreases.
con
Let's remember that we remove the gastric
la
fundus where
elongación más
ghrelin is
variable
produced the
y en
most.
la
The
malla
gastric balloon is variable, and the
se incrementa.
endoscopic sleeve is
El
increased.
GLP-1 se
Peptide
secreta en
YY
la
is
cintura
increased
de
in
los
the two
músculos,
most
el
common
GLP manga, el
gastric
GLP-YY se
surgeries
secreta
and
en el
also in
abdomen, se
the
secreta en la parte
endoscopic
común y
part.
también en la parte
Leptin
endoscópica. La
decreases
deshizo
in
disminuye
bariatric
en los
procedures,
procedimientos bariátricos.
and
Para
all
poder
this
ver esta
helps in the
figura hay que
results of
presentar la
bariatric
cirugía
surgery.
bariátrica.
Another
Otro
effect
efecto
that
que tiene la
bariatric
cirugía
surgery
bariátrica
has that we
que
need to
tenemos que
take
tener en
into
cuenta
account
es
is a
la
decrease in
disminución del
cancer
peso.
risk. In this study,
En
with a
este
large
estudio,
number of
con gran
patients,
cantidad de pacientes donde pues, ya
22,000
se
patients
establecieron
that
se estableció
underwent
la diagnosis de
MBS
que
versus
no lo eran,
66,000
se
that did
vio
not,
que
it was found
la
that the
incidencia
incidence
de
of cancer
cáncer
of
bajó
any
en
type
63%
dropped by 33%.
y
The
la
greatest
disminución
reduction in
mayor
cancer of any type
se
was
dieron en
associated
cáncer
with
de seno,
obesity,
el cáncer de
breast
seno, el
cancer,
cáncer
endometrial
esofágico y el
cancer,
cáncer
and
colorectal.
colorectal cancer, all associated with obesity.
Como toda
Like any
cirugía,
surgery,
no
it's
es
not
libre
free
de
of
complicaciones.
complications.
Las dividimos
The
entre tres
early
fases de
ones are
cirugía.
leakage,
Las son
stenosis,
puntos
bleeding,
inferiores de sangrado,
thromboembolic
efectos
events, and the
tromboembólicos.
late ones,
Y las tardías
erosion,
de erosión
obstruction,
son los cambios
gallstones,
en la vesícula,
dumping
síndrome de
syndrome,
dumping,
ischemia
isquemias,
secondary to
fundaciones de
internal
aortas internas,
hernias,
megaesófagos que sublevan la
megaesophagus,
hernia,
pseudocalacia, and
hermosas
death,
y la
but the rate of
pero la rata
complications
de
in general
complicaciones
is
es
relatively low,
relativamente baja,
0
hasta
to
el 0,6%
0.6%
de acuerdo a
in
los
the most
estudios
common
anteriores.
studies.
La mortalidad
Mortality.
es,
I always like
¿saben
to
qué me gusta
compare
comparar la
mortality in
mortalidad de
bariatric
cirugía
surgery
bariátrica con
with
la
the
mortalidad
surgery
que más
that
comúnmente
we
tiene en
do
cirugía
the
general,
most
que es
in
la
general
colposcopia?
surgery with
En
laparoscopic
este estudio, 35 millones de
cholecystectomy. In
pacientes
this
pasaron
study
por
of 3.6
colposcopia
million
para
patients,
una mortalidad de promedio de
4,707 death, the mean
0,08.
mortality was
La cholecystectomía
0.8%.
laparoscópica tiene una
Laparoscopic
mortalidad de 0,7,
cholecystectomy has a
es
mortality rate of
decir, es
0.6%,
más
meaning
peligroso, más
it's
riesgo de
has
movilidad
a
realizar una
greater
colecistectomía que
mortality
cualquiera de las
risk
vías de cirugía
compared than
bariátrica.
any
Para
modality
la
of
medida del
bariatric
calibre de
surgery.
cirugía
If we
se
divide it by
clasifica
type
el
of
obesity
surgery, OS
0,05%
has
y el bariátrico
0.5%
0,5%.
and
Si hacemos
RYGB
ya
bypass
cirugías
0.9%. If we
más
do more advanced
avanzadas,
surgeries, such as
con
the
calibre
duodenal
renal,
switch,
con unas
with
anastomías
a
más
more
brutales,
distal
el riesgo de
anastomosis, the risk
mortalidad
of mortality
va a ser mucho
increases
mayor.
a little bit to 0.40%.
Los
The
resultados
general
generales de
results
la
of
cirugía
bariatric surgery
bariátrica,
vary.
este estudio
This
lo
study
divide entre
divides it
manga y
between
bypass,
sleeve and
son
bypass.
básicamente para
Basically, to
la
not mention so many
representación,
figures,
la pérdida de
weight loss
peso
in
en
1 year is
algoritmos
very
similares,
similar. 5
5
years,
años
30.8% in the
30.8%
first year,
en el
and at
primer año,
5 years,
y a los 5 años más del
23%,
23%, mientras que la manga
where
26 a
sleeve
28%
is
en el primer año
23 to
y
28% in the
y
first
a los
year, and
5
5
años
years,
del
18
18
to
28%.
23%. Strikingly, type 2 diabetes has a very similar screening for surgeries, 81% versus
Los
83,
conocimientos físicos
hypertension
88,
17
la
versus
linfopeniemia
18,
38,
dyslipidemia
para la
38% for
pancreas,
gastric
28 para
bypass,
la
20 for
manga
gastric
gástrica,
sleeve.
la calidad
Quality
de
of
vida,
life, there's no
lo
study
bonito
that
del estudio es que,
differentiates between one and the
es la
other,
una y la otra,
but it's very
pero
significant
muy
the changes
significativos los
observed
cambios
in
observados
mental
en la
health
salud mental
and
con
physical
respecto a los
changes
cambios y
in
reconocimiento de los
patients
pacientes sometidos
undergoing
a bypass gástrico o
gastric
a manga
bypass or
gástrica.
gastric
La
band
mortalidad ya la
or
mencioné,
sleeve.
muy bajita,
Mortality, I
30 días
already
de mortalidad
mentioned, it's very low at
0,15,
30 days,
que a los
0.15%, at 5
5
years,
años 2,8,
2.8%, Same by sleeve, it's lower. Mortality at 30 days, 0.7, and at 5 years, 1.3 to 7%. reoperation in patients, although
es un poco más alto en el bypass gástrico que en la
it is a
manga.
little higher in gastric bypass
La
than in
situación
sleeve,
residual
22
se
versus
explica
18 in
la
5 years.
recuperación del bypass gástrico por
These
las vías internas, pero se encuentra relacionada
readmission
y en la manga
for
por el
resurgery in
consumo
the
de
gastric
gasto
bypass due to
esofágico,
the internal
en
ear hernias that I
personas que
mentioned,
no
gastric sleeve
sino por
due
también
to
deformaciones
GERD,
al
which
bypass
is
gástrico, que
does not
incluía
respond to
flujo,
medical
incluye
management
hemorragia.
oftentimes.
¿Cuántas veces readmisión al hospital? Por las mismas
What
causas que
are the
estamos viendo las
causes for
operaciones, 38% a
readmissions?
los 5 años
38% at
del
5
bypass,
years for
32% a los
bypass,
5 años
32
del
at 5 years
gastric.
for gastric
El
sleeve.
alcohol
Alcohol and
y los
mental
desórdenes
disorders
mentales aún
increase
generan un
slightly
riesgo
for
poco para los
patients
pacientes que
who
están sometidos a cirugía
undergo
bariátrica.
bariatric
Cuando esto
surgery when
comparado
we
con los que no están
compare them
sometidos
to
a
those
cirugía
who did
bariátrica,
not undergo bariatric
un
surgery.
porcentaje del
The at a rate of
9.2% a 9.9 a
9.2%
5 años de incidencia. Y
to
las referencias
7.9% at 5 years, the incidence and
populares
rate of
de
suicide may
cirugía
increase in
bariátrica
bariatric
individualizar
surgery
1%
patients.
cada 1000
In
personas
attempted suicide,
a los
36
5
per
años
every
a
1,000 person.
25%
At 5
individual y
years, 3.8
por cada
suicides
10.000
per
personas con
10,000
discapacidad
persons per
intelectual.
year.
Si bien cuando se
When we
compara con
compare them with
obesos no operados,
non-operated
es mayor,
obese
pero
patients,
no
it is
es
higher, but the
también
change between
significativo
operated and
de
not
riesgo a los
operated
operados y no
patients
operados
in
en
attempts and
incidentes
suicides as
y
such is not significant. So
entonces,
let's start
empecemos a comparar
comparing
la
bariatric and
cirugía
metabolic
bariátrica
surgery
metabólica
with
con los
GLP-1
y su
analogs
mortalidad
and their
incidente y
mortality.
su mortalidad.
So this is a
Entonces,
very
lo
interesting
interesante
study.
es
It
tal vez
compares
comparar a
these
estos dos,
two and
mortalidad
mortality in
y
diabetic patients. In
y
these
en estas
graphs,
gráficas, por acá, se muestra
these graphs show that
que,
if the patient has less than 10
si tiene
years
menos de 10
of
años de diabetes,
diagnosis of diabetes,
la
the
curva
mortality
de
curve of
mortalidad
those that only
desde todos van
received
a aumentar, pero
GLP-1
esta curva debería ser
analogs
un
was
poquito más alta
much
que los
higher
pacientes
than patients
que
who
fueron sometidos a
underwent
cirugía
bariatric
bariátrica.
surgery.
En los
In
pacientes
patients with
con más de
more
10
than
años
10
de
years
cirugía
of
bariátrica,
diabetes,
diabetes,
the
perdón,
curve is very
la curva es
similar.
muy similar.
That is,
Hubo una
there was no
discrepancia en la
difference in
mortalidad
mortality
de los
between
pacientes
patients who
que fueron
underwent
operados, pero que
surgery
llevaban más de
but
10
that
años
had
de
more
diabetes.
than 10 years of
Y en
diabetes.
este
In the
mismo
same
estudio, cuando se
study,
comparan los
when they
efectos
compare adverse
cardiovasculares adversos,
cardiovascular events, the same
pasa
thing
lo mismo.
happens.
En los
In
menores de
under
10
10
años
years, there is
se
a
nota la
difference
diferencia
in
de
patients
los
who were
pacientes que fueron
operated
operados
versus those who
con
only
los que
received
fueron análogos,
analogs.
pero en los
But in
pacientes que probaron
patients who had more than 10 years of
más de 10
diabetes,
años
the
no
curve is
ocurrió
very
ninguna
similar.
similar.
There
O sea,
was
no hubo
no
un beneficio a más de 10
mortality
años
benefits
que
in
llevan
patients
más
with
de
more than
10
10
años
years of
de
diabetes who
diabetes
had
que fueron
surgery.
operados.
When we compare
Cuando comparamos las
weight
personas
loss
la pérdida de
and
peso
GLP-1
con los
analogs,
GLP-1,
we
encontramos
basically found in this
claramente en el
study, it's a
estudio que los
meta-analysis of 6 studies, 332 patients. In a
en los grupos
randomized
randomizados
trial,
encontramos
we found an
una
advantage
ventaja para
for
la cirugía de la pérdida de
weight
peso de
loss surgery of
22,68 kilos,
22.68
midiendo grasa
kilograms,
corporal en
BMI
grado líquido
8.18 kilograms per
para
square
la
meters,
cirugía
more for the
del
surgical group
grupo
than
oncológico.
the
Y la hemoglobina
um,
glicosilada disminuyó
medical
en uno
group,
punto
and
2% porcentual.
HbA1c decreased 1.20% more in
Los
patients
estudios
that
bilaterales
underwent
comprueban
surgery.
valores
International
muy
studies prove
similares
these
en
very similar values in benefit towards
hacia
metabolic
cirugía
surgery
metabólica.
compared to analogs. This
Un
trial
estudio
is
muy
very
importante
important,
es
is a
un análisis
meta-analysis,
sistemático de literatura
a systematic literature
de
review,
las
which
cirugías
concludes that
asociadas
surgery
a
associated with
cada uno de
better
los
long-term
pacientes
results than
para
pharmacological treatment for obesity.
para la obesidad.
What
Se
did
revisaron
they
147
review?
pacientes similares a
6,719 articles,
todos
427
los
patients
estudios
were
fueron
reviewed. All studies were
revisaron, fueron
randomized,
randomizados,
controlled.
controlados,
3
y
had
ellos tenían
5-year
seguimiento a
follow-up,
5
and
años
2
y
had
10
10-year
años.
follow-up.
Y que en
What
su
was
control,
found in
a
favor
favor de
of
la cirugía
bariatric
bariátrica,
surgery?
mejora
Better
de pérdida
weight
de
loss,
peso, mejora de
better
valores,
values,
disminución del
decrease in
colesterol total,
total
disminución del
cholesterol and
triglicéridos, disminución
triglycerides,
en el
and
riesgo
increase in
de
HDL,
hipertensión y la presión,
decrease in
una
systolic
disminución en las
pressure,
cirugías
decrease in
torácicas,
diastolic
un
pressure,
mejor
improvement in
en valores de
HbA1c
glucosa
values, and
asociada,
as I mentioned before,
un mejor
a
riesgo
greater
de las
decrease in
progresiones y
cardiovascular
para
risk for the
cirugía.
surgical group.
Pero así como la
But such
cirugía
as
funciona
surgery
y ha
works
mostrado tan buenos
and
resultados,
has
también
shown
puede
good
fallar y da
results, it can
promedio
fail.
la
And an
cirugía
average bariatric
bariátrica tiene
surgery
una ganancia de apoyo a
has
los
a
5 años de
5-year
aproximadamente un
weight regain of
17%.
approximately
Varios
17%.
estudios
Some
han
studies have
mostrado que son
shown
similares
that
por la
there's
parte del bypass,
similar
otros
uh,
se
uh,
inclinan a que el
with
bypass tiene
bypass
mayor
that has a greater
mantenimiento en la
maintenance in
pérdida de
weight
peso, pero
loss,
cuando
but when
falla,
it
pues se
fails,
puede
what
utilizar
can
en la
think on
adjuvación y adjuvancia
adjuvancy or
en el manejo de la
neoadjuvancy
obesidad.
for managing
Cuando
obesity?
se
This
revisan
is an
los
article that
pacientes
was
con
published
resultados
this
de
year.
ASO,
There are several studies with orlistat, with
con
Fentera chloramine, topiramate with liraglutide, semaglutide, and others with multiple anti-obesity drugs. Basically, here I want to
Básicamente quieren
show
mostrar
these with
con la
liraglutide that were available in Latin America.
Latinoamérica.
In this study, they
En
compared
este estudio
patients
compararon
who had
pacientes
gastric
que le hicieron
sleeve
manga gástrica
with liraglutide 3 milligrams versus those that only had gastric sleeve. Which patients? Patients with a BMI greater than
Entonces era una
30
mujer mayor de 30 que, pues,
who
que le
underwent
hicieron
gastric
una
sleeve,
manga gástrica,
was
que
started 6
inició a
weeks
las 6
after
semanas
surgery,
después de haberse operado
and they
y
studied
se
them for
estudió por
24 weeks
24
and
semanas
found
después
that
de que
the
el grupo
liraglutide
de
group
liraglutide
had a
era el
higher
grupo donde
percentage
estaba
of
en mayor de
total
pérdida
weight
total de
loss and a
peso
higher
y un
percentage
porcentaje
of
mayor
excess weight
de
loss
exceso de peso
than the
mayor que el
group that
grupo
did
control.
not receive liraglutide. This is a
Este, que es
prospective
un estudio
trial
prospectivo
where
donde
patients that
pacientes que
receive
recibieron bypass gástrico o
gastric
manga
bypass or sleeve and
y
then
después
receive
recibían
0.25 to 1
0.25
milligrams
1
of
miligramo de
semaglutide weekly.
semaglutide semanal.
Post-surgical
Pacientes
patients who had an
que tenían
inadequate
una
weight
pérdida
loss
inadecuada de peso
or that
o que
had
habían
regained
reganado peso.
weight. When
¿Cuándo se
did they
comenzó el
start this
tratamiento?
treatment? In
No desde
average
los siguientes
64
4
months
meses
after
de haber
surgery.
sido operados.
The treatment lasted
Duró ese
12
tratamiento
months.
12 meses.
What was found
Encontraron
is
que
a
los
patient
pacientes
that
que
received
recibieron
semaglutide
semaglutide
lost more
más
weight
peso
with a
en su tratamiento
significant P
continua
than
que los que
those who
solamente
only
continuaron el
had
tratamiento con
conventional management with
semaglutide
lifestyle
puro
changes.
y que
The
volvió
group that
rápidamente
received
a su peso
liraglutide
anterior.
improved weight loss. And in this other group, they compare liraglutide and semaglutide in operated patients with sleeve,
O
gastric
manga
band who
gástrica
received
que
liraglutide
recibieron liraglutide 3 miligramos al día
3
o
milligrams a
especialmente
day,
en
or
ese
those
otro
that
grupo, los que recibieron
receive
semaglutide
semaglutide
90
1
miligramos
milligram a
diarios.
week.
92 para el
92
grupo de
for
liraglutide,
liraglutide,
15 para el grupo
115
de
for the
semaglutide
semaglutide group.
y eran
These were
pacientes
post-surgical
postquirúrgicos
patients
que tenían
who
reganancia de peso.
regained
Entonces,
weight.
¿qué se
What
encontró?
was
Que los
found is
que
the
recibieron
semaglutide
semaglutide
group
tenían una
had a
iba
significantly
manteniendo esa
greater
pérdida
total weight
del
loss
total de
in the
peso
group
en
than
el
the
grupo de
liraglutide group.
liraglutide. En el
12% for
12% para
semaglutide,
semaglutide y
8% for
para el
liraglutide.
liraglutide.
We need more
Necesitamos más
trials, more
estudios,
protocols
protocolos que nos digan
that tell us
exactamente
how we're
cómo
going to
vamos a manejar
manage
esta terapia
these
ayudable
adjuvant and
completa,
neoadjuvant
que nos digan
therapies, when
cuándo la
to
vamos a
use
usar,
them,
desde el
how
desde
long
antes, qué
before,
tipo
in which
de
patients,
pacientes,
which
cuál
drug
medicina
will we
vamos
use,
a
for
utilizar,
how
por
long,
cuánto tiempo
before
antes,
and
cuánto tiempo
after,
después y
and
cuáles
what are the
pacientes son los
patients
que
we should
deberíamos
choose,
elegir
or what
o qué
parameters
parámetros
are we
vamos a
going to
escoger
choose to
para
decide
decidir
if
si
a
el paciente
patient
va a
will
recibir o
receive
no
or not
adjuvancia o no
adjuvancy
adjuvancia
or
de medicina.
neoadjuvancy treated obesity. How
¿Cómo
to
escogerlo?
choose
Pues
them?
el
What
régimen
regime? We must
tenemos
consider several
considerar varias
things:
cosas, el
cost,
costo,
insurance
la cobertura
coverage,
del seguro, los
adverse or side
antecedentes,
effects,
las
contraindications, and
contraindicaciones y
individual
las
patient
prioridades del
preference,
paciente, los antecedentes del paciente y
family
las
history,
posibilidades del paciente. Paciente
comorbidities.
con
If the
diabetes,
patient
pues
has
si
diabetes,
recibe
he would
semaglutide,
benefit from liraglutide or
puede ser paciente
semaglutide.
con un
But if a
factor de
patient
riesgo
has a
mayor,
major
pues
depressive
una bupropión pues puede ser
disorder,
una elección.
naltrexone and
Una
bupropion would
única
be the drug of choice. In Latin
alternativa
America, only
es
liraglutide is available. As a
como conclusión
conclusion, the
a
question
esto,
would
la
be,
pregunta sería,
will
¿la
bariatric
cirugía
surgery
bariátrica
be
será
replaced
reemplazable
by
por
medical
cirugía médica?
management? Well, probably not, for
Probablemente
several
no, por
reasons.
varias
First,
razones.
the
Primero, por las contraindicaciones que
contraindications
tengan
of the drugs,
los medicamentos,
because of the patient
por el estado
choice,
del paciente, por
tolerance
la
to the
tolerancia
drugs,
a los
or
medicamentos o
simply
porque
failure
simplemente
of
fallamos en
medical
el manejo.
management.
Entonces no sería
But we
recomendable.
should
Pero también
also,
deberíamos decir que,
well,
digamos,
and
nos
it's
falta
necessary as well
evaluar
to
si
evaluate
también
that
la
bariatric
cirugía
surgery
bariátrica
does reduce,
está
and
comprobado
it has been proven that it reduces the risk of cancer.
pero también podríamos decir que probablemente sí
But
la
we can
reemplace,
also say that
porque
probably
los
it will
avances en los
replace it because of
medicamentos
advancement
han
in drugs.
incrementado la
The
tolerancia,
tolerance has improved,
tienen
there are better
mejores
results,
resultados.
and there is
Hay
historical
casos
data
donde el
where medical
tratamiento médico
management
sí ha
has
reemplazado el
replaced
manejo
surgical
quirúrgico.
management. And I bring you
Les
two
traigo dos
examples:
ejemplos. El
omeprazole
omeprazol o los
for,
inhibidores de la bomba de
for
toxones
PPI
y el
inhibitors
inhibidor
that
de la
decrease or
bomba
rather
hipogonadotrópica,
abolished
la
gastric
cirugía
surgery for
gástrica
benign
por enfermedades
disease.
químicas.
We no
Ahora ya
longer
no
do a
operamos
surgery on
esofagoplástica,
gastric
ya no operamos las
ulcers.
esofagoplastias,
We
ya no
don't
hacemos
do
esofagotomías, porque
pyloroplasty
los
or
inhibidores
vagotomies
reemplazaron
because
el
PPIs replace
tratamiento y ya no lo necesitan. O en
surgery.
el tumor de
Or
recto,
in
donde era
rectal tumor
neoadjuvante,
with
pues
neoadjuvancy
ya
that
se ha
has
demostrado,
demonstrated
ya se ve
that with the
con el
management
manejo
of chemo and
quimio-radioterapia, el
radiotherapy,
paciente con una
patient
respuesta
with a complete
completa puede
response can
evitar
avoid going
ir a
to
la
a surgery.
cirugía.
Therefore, I
O
think
también si yo
that
pienso que los
drugs are
medicamentos
complementary
son
to surgery,
complementarios a la
both
cirugía,
when
tanto
they
para cuando
fail as
fallan
well
como
as
también
to
para cuando tienen
evaluate them in
respuesta
a later response
cuando se
when there is a
necesita
need where
que fallan
there is a
en la
failure
pérdida de
in
peso
management
o usarlos
in
como
weight
adjuvancia en
loss
los
or to
tratamientos
use
en el
them
paciente súper
as
obeso que
neoadjuvants in
hemos hecho
super
evidencia que cuando se
obese
está dando la
patients.
cirugía
It can
podrían ser
be
complementarios con la
complementary
neoadjuvancia para
to neoadjuvancy for surgical management of obese patients. Finally, I would like to leave you some recommendations of the American Association of Metabolic and Bariatric Surgery and the International Federation on Obesity Surgery, where they have decreased the indications for surgeries. Patients with a BMI of 35 to 40 with or without comorbidities should be a candidate for bariatric surgery, and patients with a BMI of 30 to 35 with metabolic disease that are not responding to medical management. That is, that medical management is not effective, should be candidates for bariatric surgery, especially if their diabetes has been present for less than 10 years. Depending on the race in Asian, for example, BMI 27.5 is an indication for bariatric surgery. Thank you very much. This is a picture of my surgical team. Thank you for the invitation, and we look forward to the round of questions.
Muchas
Thank you,
gracias,
Dr. Manrique
doctor
and Dr.
Manrique
Forero.
y doctor Forero.
Excellent conferences.
Excelentes conferencias.
There are many
Hay
questions.
muchas preguntas. Yo sí
I would
quisiera
like to begin
empezar
with Dr.
primero con el doctor
Manrique
Manrique,
because this is a
porque es una
question
pregunta
that
que
is
la están
being
haciendo
asked very
frecuentemente.
frequently. Are there
Si
any
hay estudios
controlled and
controlados
randomized
y
trials
aleatorios sobre
on
el
the effect
efecto
on the
a
pancreas
nivel del
with
respect
respect to
relacionado con los análogos de la GLP-1,
GLP-1
pero
analogs, particularly
específicamente
with
con el
pancreatic
cáncer
cancer?
de páncreas.
Very good question.
Muy
Because
buena
of the
pregunta, porque
great use
claramente
of
estos
the
análogos de
GLP-1
GLP-1
analog,
no siempre se
we
hace la
always
pregunta
ask
del
ourselves
riesgo
the
de cáncer
risk
de
of
páncreas.
pancreatic
Te
cancer.
comento que no
But
existen
there are
estudios
no clinical
monitorizados y
trials,
ensayos
either
clínicos que detecten
randomized or
cáncer de
controlled.
páncreas.
But we do have
Lo que existe son los
reports.
reportes
But that
por
is
ahí,
more
pero más que
related to
todo eso es relacionado
pancreatitis.
a
And it
pancreatitis.
is always
Y que es
important as a
importante
critical
siempre,
point in
como uno de los
clinical history,
puntos
to
críticos de
ask
la
if
historia clínica,
there
es preguntar si
are
hay litiasis vesiculares
gallbladder
o
stones
historia
or
de cólicos vesiculares, que eso también es
gallbladder colic
una
that
condición
is the
venible para
contraindication
análogos de GLP-1
for
hasta que se resuelva la condición de la
GLP-1,
litiasis
but
vesicular.
pancreatic
Pero cáncer
cancer
de
does not
páncreas no
exist
existe relación frente a ello con
with
respecto
any
a
clinical
ensayos
trials, and
clínicos, y la
pancreatitis is
pancreatitis
a
realmente es una
condition that is
condición
associated
asociada
to
a esta situación de la
gallbladder
litiasis
stones and
vesicular y
is not
realmente
very
también es
frequent.
poco frecuente.
This is a question by
Esta
Dr.
pregunta la
Guillermo
hizo el doctor
Latorre.
Guillermo Latorre,
Sorry that I
apenas se
didn't
me olvidó
comment it,
comentarlo, y la pregunta el
from
doctor
Dr. Amin
Ahmed
Aguilar from
Aguilar
Peru.
de Perú, y sobre
What
todo
experience do
la
you have in the
experiencia que tiene
combination
sobre la
of
combinación de los
GLP-1
análogos
analogs
del
and
GLP-1
topiramate
y
phentermine
topiramate
in
fentermina.
combination? Excellent question, because
Excelente pregunta, porque eso se planteaba
when we
de
treat
las
a patient
condiciones.
for
Cuando uno
weight
trata un
loss, we see
paciente
two
para bajar
things:
de peso, ve
efficacy
dos
and
cosas,
safety.
eficacia y seguridad.
So I think
Entonces,
that
pues yo creo que los análogos de
GLP-1
GLP-1 son muy
analogs are very
eficaces,
effective, but their
pero tienen un
mechanism of
mecanismo de acción muy
action is very
diferente
different
a
from phentermine
fentermina y
to pyramide.
topiramato.
That's
Por lo
why, from
tanto,
the
yo, desde
standpoint
el
of
punto de vista
evidence,
de
there's
evidencia,
no
no existe un
clinical trial
ensayo
of
clínico de
combination between
combinación entre análogos de
GLP-1s
GLP-1 y
and
fentermina
phentermine to
topiramato.
pyramide,
Lo que
but we
tenemos
do
es
have
experiencia.
experience, and
Y la
experience
experiencia
shows that we
refiere
can
que
use
sí
them
se pueden
in
usar y se pueden
combination, and
asociar,
there is an
y
additive
también hay un efecto aditivo con
effect for
respecto al
appetite
control del
control. But as
apetito.
I
Pero
said in
como
my
dije en
conference,
la
we need to
conferencia, hay que
individualize each
individualizar
case,
cada
because if
caso,
I add more
porque si yo
drugs,
adiciono
add
más
more
fármacos,
adverse
tengo más
or
eventos
side effects,
adversos
and
y pues
safety
baja la
is
seguridad.
decreased. That's
Pues
very
eso es muy
interesting, because
interesante
remember
porque
that
acuérdate
phentermine
que fentermina
increases
es,
adrenaline
eleva la
and
adrenalina, las
catecholamines, and
catecolaminas, y
topiramate
topiramato
has a
tiene
GABA
mucho GABA,
effect on
son
the
sistemas
central
nervioso
nervous
central,
system, and it
y lo cual
confers
le confiere
other
otro tipo de
side
eventos
effects.
adversos.
So we
Por
can
lo
add
tanto, sí
them,
se
but
pueden adicionar, pero
I'm
siempre
always
te plantearé
attentive to
que
adverse
estoy muy
events that
atento a
can
los
be
eventos
added with
adversos que se puedan
combination.
adicionar
And
con las
there's
combinaciones,
always
y
a
siempre hay
secret in this. It's
un secreto
titration
y
of the
es
dose. We have to
titulación de las dosis.
titrate
Uno
drugs.
tiene que titular los fármacos.
GLP-1s and
Los GLP-1
titrated,
los
and
titulo
phentermine
también,
or phentermine
fentermina o
topiramate
fentermina
need
topiramato, se
titrate to
titulan
have
las dosis
less
para tener
adverse
menos
events.
eventos adversos.
And finally,
Por
to give the
último,
floor
ya
to
para
Dr.
darle paso a la
Imperia,
doctora
there are
Imperia,
many questions
hay
that
muchas
have been
preguntas
asked,
que
and
se han
this is for
dicho
both.
y esta es para los
What
dos.
treatment scheme do
¿Qué
you have
esquemas de
after
tratamiento
gait
tienen después de la
regain,
regadera
after
de peso de la
bariatric
cirugía
surgery,
bariátrica, bien
whether
sea bypass,
bypass
bien
or
sea manga
sleeve,
gástrica? GLP-1 o
GLP-1s
usted es el que
or
tiene
topiramate and
con
phentermine,
topiramate y
Dr. Heller,
fentermina.
or
Y
as
lo otro decía el
Dr.
doctor
Forero was saying,
Forero,
the
que
study
los estudios
he
que nos
showed
mostró,
compared to
pues
bariatric surgery
comparado con la
probably
cirugía
are
bariátrica,
done with
probablemente se hicieron con fármacos
drugs
que
that
no bajaban,
just
sino
dropped
dígitos,
one
no dos
digit.
dígitos como son los actuales.
So could
Entonces
each one of
quisiera
you
que cada
please
uno me
respond to
respondiera
these
a las
questions
preguntas que
by
han
the
hecho
attendees?
todos los asistentes.
Bueno,
If you
doctor
allow me
Hernando,
to
si me
begin,
permite comenzar,
what will we do
¿qué hacemos
with
con
a
un paciente que es de cirugía de
bariatric
peso que ha
surgery
reganado
patient
peso?
with
¿Cómo lo
weight
enfocamos? Entonces,
regain?
lo primero,
First,
tengo que
a
decirles
patient
que
that
el
regains
paciente que
weight
regana
is
peso
usually a patient that is
absolutamente se
lost
pierde en una
from
consulta.
our
Ese
outpatient
paciente no
office.
es el que vuelve.
They don't
Desafortunadamente,
return.
el que va bien, sí
Those that
va
are
a todos
doing
los
well,
chequeos
they
y
do
tratar
come
de
to
los
their control.
procedimientos. El que
If they
va
regain
a echar a
weight for
ganar
whatever
peso,
reason,
por la
they don't
razón que
come back.
sea,
But when they
no
do,
regresa. Pero
first
cuando
we try
vuelve,
to
intentamos
seek for an
primero buscar
anatomic
una
cast.
causa
Cause
anatómica. En el
in
caso del
bypass,
bypass,
no
buscamos
gastrogastric
que no haya una fístula
fistula
gastrogástrica
that
que
is
haga que no
hindering
pierda
weight
peso.
loss, or
Un
a sleeve
bypass
with a lot of
manga que causa
reflux
reflujo puede
makes a
hacer que el
patient
paciente
eat
coma más,
more
entonces eso
times a
recibe y
day
gane
and
peso.
regains weight, and then
Entonces
we
lo que
do
hacemos
an
primero es pues endoscopia,
endoscopy
radiografías
and X-ray
gástricas
of the
y
upper
lo que sí hacemos,
gastric
y el doctor Duque lo sabe, es
ways, and we
rápidamente
rapidly
tratar
send
de
them to
mandarlo a
endocrinology to
endocrinología
help us
para que
with
nos ayude con los análogos del
GLP-1
GLP-1 a
analogs so
volver
that they
o a mantener
return
la pérdida
and
que ya se ha
lose that
logrado
weight
o a volver a
they
perderla la que
had
ha reganado
regained
después de
after
la cirugía.
surgery.
En una de las preguntas
And
también
one
que
of
se
the
hacían,
questions we
nos
were asked
decían
how to know
que
if the
cómo
patient
saber si
failed
el
the
paciente
surgery.
falló la
And
cirugía bariátrica y
basically, when
básicamente
the
uno
patient has
contempla
not
cuando
lost
el paciente no ha
80%
logrado
of their
perder el 80% del
overweight at the
sobrepeso
moment of the
del momento de
surgery.
la
That
cirugía.
is the condition. Just to
Gracias.
add two
Solamente
things.
agregar dos
I have
cosas.
many
Yo
patients that come
tengo
for
muchos
1, 2,
pacientes que
3 years,
vienen 1
and
año,
they
2
come
años, 3
with
años
weight
con regancia de
regain.
peso.
And I
Y lo
always
que yo siempre
tell them,
les digo,
let's
empezamos
start
de
all
nuevo.
over again. How do we
Empezamos de
start
nuevo.
with a
¿Cómo
good clinical
empezamos?
history,
Una buena historia clínica,
multidisciplinary
manejo
management, and
multidisciplinario
nutritional
y
therapy
la
that is very
terapia
important?
nutricional, que
Why
es
weight
importante, porque
regain?
reganaste
You
peso, porque
didn't
no
learn how
aprendiste a
to
comer
eat. Your
realmente, tu
behavior didn't
conducta no
improve. So
mejoró.
we need to go
Entonces
back to
tenemos
that.
que reingresar
And
al tema.
I just
Y yo les
help
ayudo de la
myself
terapia
with drugs.
farmacológica, no hay duda.
Undoubtedly,
Pues
we
elegimos el
choose
fármaco que le convenga al
according to the
paciente, porque hay que
patient's
elegir de acuerdo al
phenotype.
fenotipo del
And in these
paciente. Y
conditions,
en
we
esas
start a new
condiciones
stage
empezamos
that
una
would
nueva
be
etapa,
weight
que
loss.
es,
What
a
is
ver,
the
pero ¿cuál es
advantage?
la
They
ventaja de
have a
este
bariatric
paciente? Tiene una
surgery.
bariátrica. ¿Y qué es lo
What
que sucede
happens? Once
generalmente?
again, they
Vuelven a perder
lose
peso.
weight. But
Pero
we
¿qué
need to
sucede?
accompany them,
Acompañamiento,
motivate them, and
motivación.
this
Y
generates two
creo que eso
conditions. The
genera dos
patient
condiciones, que el paciente se
realizes
dé
this
cuenta
is
que
a
es un problema de por
lifelong
vida,
condition.
pero
They
vuelven a
lose
perder
weight again,
peso.
and it's
Y es
interesting when they
interesante, no hay
have
duda, cuando
a
tienen una
sleeve,
manga
their
gástrica
stomach
tendido,
is
estómago
small, and
reducido,
they
y
lose.
vuelven a
If
perder
they have
peso.
a
Cuando tienen
bypass,
una
they lose
derivación,
weight.
vuelven a perder
That
peso.
is why
Por eso
clinicians
los
need to
clínicos tenemos que entrenarnos
train
desde
ourselves in
tiempo en
management
el
after
manejo
bariatric
posterior de la
surgery.
cirugía
Our surgeons
bariátrica.
are very
Nuestros
good
cirujanos
doing
son
their
muy
surgery,
buenos operando,
but they don't have
pero ellos
time
no
for
tienen tiempo
follow-up
para hacer
because they're
seguimiento de
good
los
surgeons.
pacientes, porque ellos son buenos cirujanos.
When
Así
we
como
are
dice la
surgeons,
historia cuando hemos sido
we
recién,
say
¿no? Cirujanos
surgeons are
enfermeros,
surgeons,
médicos
clinicians are
médicos.
clinicians,
Esta
right?
es una enfermedad médica. Gracias.
Dr. Imperia?
Doctora Imperia.
Well, we have another question.
Bueno, hay otra
Efficacy
pregunta,
of
es eficacia de los
GLP-1s at
GLP-1
the
a
long
largo
term, and
plazo
what is the
y cuál es
criteria
el
to
estudio
when
de cuándo suspender
suspended,
o cuándo
when to
volver
continue,
y
and
cómo
how,
ayuda.
if you have any
Si hay
trials?
estudios de eso.
Dr. Tony Saba from
Doctor Tony
Venezuela,
Saba de
Dr.
Venezuela y
Carlos
el
Aristizábal
doctor
from
Carlos
Colombia, and Dr.
Aristizábal de
Carolina
Colombia y
Brandao
la
from
doctora
Panama.
Carolina Brandao de Panamá.
Interesting question because it talks
Interesante
about
pregunta porque
efficacy.
habla de eficacia.
Efficacy depends on
Eficacia
how the
depende de cómo los
GLP-1s between
GLP-1 pues más o
70,
menos entre el
60% of the patients
70%,
can lose
60% de los pacientes
15%,
pueden
but there's
perder
a
un
20,
15%, pero hay un
30% of patients that do
20-30%
not
que no
respond.
responden.
They're called
Y se llaman los no
non-responders.
respondedores. No
Non-responders with
respondedores por
different
diversos
reasons because
motivos,
they don't have
porque
an ideal
realmente no es el
phenotype,
fenotipo ideal,
because they have
porque
another
realmente tienen
condition
otra
from a
condición
clinical
desde el punto de
standpoint,
vista
the
clínico, el
duration of
tipo
their
de
disease, their
enfermedad,
genetics, and in these
genética, y en
conditions,
esas
like
condiciones
guidelines
justamente
say,
como
we need
dicen
to
las
wait
guías,
for three
hay que
months
esperar
so
unos
that
3
they
meses
lose
para por lo menos perder
5%
un
of body
5%
weight
de peso
to
corporal para
change
hacer el
treatment
cambio de
or to add a
tratamiento
treatment.
o adicionar un
But I
tratamiento.
consider
Pero
that
considero que
GLP-1s
los
are a good
GLP-1
strategy
son una buena
if
estrategia siempre que se
we
haga
do
de
a
esta
clinical
condición.
history,
Historia
nutritional
clínica,
management that is
manejo
correct, and a
nutricional
correct
correcto y manejo
pharmacological management.
farmacológico correcto.
When do
¿Cuándo
they
falla en el
fail treatment? When
tratamiento?
you give the
Cuando se
drug
da de
and you
frente el
don't give an
fármaco y no se da
appropriate
un adecuado
nutritional
seguimiento
management
nutricional
of the
del paciente
patient.
y de
I think
conducta.
this is
Y que creo que
fundamental
eso es
so
fundamental
the
para que el
drug has the
medicamento
best
tenga una
efficacy.
eficacia de lo mejor
Sometimes it's
y
even
que
greater
muchas
than
veces
what
supera
trials
hasta
say.
lo que
You lose
dicen los
20,
estudios. Te das cuenta que
25%.
pierden
The patient
porque, oye, el paciente se pone la
lose
camiseta
a lot of
y
weight.
realmente pierde mucho peso.
Non-responders,
Los no respondedores
let's
no
not
hay que
leave them
dejarlos de
aside.
lado
They
porque
are
realmente ellos tienen
anxious to
muchas ganas de
lose
perder
weight,
peso.
and we have
Tenemos
many
muchas herramientas
drugs
farmacológicas
we
hoy
can
día
add.
para
And I
adicionarle
think
y
that
que creo
bariatric
que también
surgery
la
is
cirugía
another
bariátrica se
extra
vuelve una
tool. If the
herramienta más,
patient
porque
doesn't
si el
lose
paciente no
weight
puede
with
perder con anabólicos,
combination
GLP-1
therapy
con terapia
or
combinada, viene la siguiente
GLP-1s, then
grada,
we
que
have a
es
next
la
step,
cirugía
which is
bariátrica como otra
gastric
estrategia para que el paciente
surgery. That's
pueda perder
why
peso. Por eso
I
yo soy un aliado de la
believe in
cirugía,
gastric
cirugía
surgery. It's
bariátrica.
very
Por
important,
eso creo
and
que es muy
Dr.
importante que el
Forero has
doctor
said
Forero no
so.
me
There are
dejará
many
mentir,
patients
que pues hay
that
muchos
can't
pacientes
lose
que
weight
son, pues no
only
pueden
with
perder peso con
medical
terapia
therapy.
médica.
That is correct.
Y
And what you said is a
correcto, y
key
usted
word.
ha dicho
It's
la palabra
follow-up
clave, es
and change in
independiente del
patient.
cambio del paciente.
Surgery and medical
La cirugía y
therapy
el tratamiento médico creo que son
is not the only
lo
thing.
único. Si el
Patient
paciente no
needs
pone de su
to
parte, se quedará
contribute
con los
and help.
resultados
Otherwise, it
que
will not receive the correct
¿Y
results.
cuál es la opinión de la
In
banda
your opinion,
gástrica,
Dr.
los
Francisco
especialistas en
Herrera,
Perú,
your opinion
al
on
respecto y la
gastric band
el
in
efecto
long-term success compared to others?
comparado con las otras
Well, the
Bueno, la
gastric
banda gástrica en
sleeve
realidad
is
es un procedimiento que cada
procedure
vez
we
vemos
see
menos.
less and less, or the band.
La
The
experiencia que
experience
nosotros
we
tenemos
have
en mi
is
grupo con banda gástrica
remove
es
it
retirar
to
la
do a
banda gástrica y
conversion to
convertir
another
la
type of
banda
surgery.
gástrica a otro
We
tipo de
can do it
cirugía.
the same
A veces
procedure
lo podemos hacer en el
sometimes,
mismo
other
procedimiento,
times
a
we
veces
only remove
solamente
the
retiramos
band
la
and
banda
then
y en
we
el
convert
siguiente tiempo
that
convertimos esa
band
banda
to a
a manga
sleeve
o a
or a
bypass.
bypass.
¿Cuál es el
What is the
problema? Que
problem?
uno, primero
The results weren't
los
good, and
resultados
second,
reales,
the
pues en ese
complications
mundo las
we had,
complicaciones que teníamos al
the
reducirse la banda
band
con el
gets
tiempo,
smaller in
el
time in
dolor
the
es total.
stomach. Sometimes we
Algunas
left them
veces
there
las
because
hemos
it's
dejado ahí porque es
impossible to
imposible
remove them.
quitarlas, es más
It
daño
would
que
cause
uso,
more
pero la
damage.
experiencia
But
que
the
estamos
experience
teniendo
we're
los
having
cirujanos
as
que
bariatric
hacemos ahora
surgeries
cirugía
is to
bariátrica
remove
es
bands and
retirar
do a
bandas y
conversion to
convertir a
another
otro
type
tipo
of
de cirugía.
surgery. Regarding the gastric balloon in adults and adolescents, Dr. Well, the gastric
Bueno,
balloon in
el balón gástrico
adolescence
en
is very
adolescentes
useful
presenta
if the
una gran
patient doesn't
utilidad
want to
cuando un
be
paciente no
subject
quiere
to
ser
a surgical
sometido a
procedure.
un procedimiento
And in
quirúrgico.
adults, basically,
Y en
we're
adultos,
using
básicamente, lo
in
estamos
super
utilizando en
obese
pacientes
patients
súper obesos,
where in
donde
preparation for the surgery, put
preparatoriamente
the
para la cirugía
intragastric
colocamos el balón
balloon
intragástrico en
if their
pacientes con
BMI
índice de
is
masa
greater than
corporal mayor de
50,
50.
200,
Estoy hablando
250
de 200,
kilograms.
250
We
kilos.
put
Después
them
le
in the
quitamos el balón
balloon, 6
intragástrico,
months with the balloon.
6 meses
We
de terapia
remove
con
the
el balón,
balloon, and in the
retiramos el
next
balón
weeks,
y en las
after
siguientes
removing the
semanas,
balloon,
después de
we
retirar el balón, le
the
hacemos el
procedure. It
procedimiento.
helps
Nos
us
ayuda
as
más
a
como
neoadjuvant, as a bridge to
neoadyuvante
the
para el
surgery.
procedimiento, para que la cirugía sea más segura.
In your experience in children and adolescents, among the
Pues,
drugs or between drug and surgery, what would you choose? Dr. Carmen Rojas from Venezuela. Experience in adolescents and children.
Bueno, para hablar de la cirugía
In
bariátrica en adolescentes,
Colombia,
en Colombia está
the
autorizada
surgery
la
is
cirugía desde
approved
los 15
between
años
the
hasta los
ages
75
of 15
y
and
la experiencia que
75.
tenemos es que en mi grupo
Our
hemos
group
operado a
has
muchos
done
adolescentes, es hacer
sleeve
manga
in
gástrica. Tratamos de no
adolescents.
hacer
We
una cirugía
tried
mixta, una cirugía
to be more
malasortiva, sino solamente una
restrictive
cirugía
than
restrictiva,
uh,
por lo que lleva
to
tanto
cause
tiempo por las multivitaminas y
poor
ese tipo de cosas.
absorption,
Y los
and we
medicamentos para
add
eso son así como
multivitamins.
los
Dr.
medicamentos.
Manrique,
Bueno,
how would
un
you
comentario que es muy
manage
importante.
it?
Y autorizados para después de los
Authorized
12
after
años,
12
fármacos
years,
GLP-1,
GLP-1,
semaglutida,
semaglutide,
liraglutida y fentermina
liraglutide,
topiramato.
phentermine,
Fentermina solo
topiramate,
mayor de 16 años
phentermine
y
for
creo que
older
es
than
muy importante
16.
ver
And all
que
these
todos
drugs
estos fármacos
need
necesitan
behavioral
acompañamiento desde el punto de vista
accompaniment, and
conductual
I think
y que
family
enriquece el
accompaniment,
acompañamiento
because
familiar. Porque dar
to
un
give a
fármaco de estos
drug
tipos
of
a un
this type to a
pequeño de 13
13-year-old,
años,
there are
pues hay
significant
cambios que
changes
son
in their
importantes desde el punto de
behavior.
vista de la conducta de
So
estos
we need
muchachos. Entonces,
psychologists, we also
necesitamos de
need
psicólogo,
neurologists,
necesitamos también de la
and the
nutrióloga
family
y un
accompaniment
acompañamiento familiar que es
that
pues
is
pleno durante todo
essential
el
during
control
the following
de los
years.
años
And remember
progresivos.
that in
Y
Peru,
recuerda que
we
en
don't
Perú
have
tenemos obesidad no tan
severe
severa
obesity
como
like in
muchos
the
en Estados
US.
Unidos.
Like
Los índices
children and
parece que en
adolescents
Estados
in
Unidos
the
tienen
US,
entre
they have
35 o 40 percentiles por
35,
encima de
40
los 75 acá.
percentile. Of,
Percentiles
and
75-90,
here
pero
we
dice porque
have
pues
some,
esperan los
they're
próximos
in
años si
the
no tenemos
75, 90
alguna
percentile.
condición
But that is
desde
what's
el punto de
coming
vista de
up in
salud
the
pública,
future
porque
if we don't
recuerda que tenemos
control
la
this
obesidad en edades
public
muy
health
tempranas.
problem.
Bueno,
La
sí,
empagliflozina como único medicamento en el
Phentermine
paciente
as the only drug
corporal
for
o
reducing
Fabián
body
Trujillo
weight.
de
Dr.
Colombia.
Fabian Trujillo from Colombia. What was the question? Sorry.
¿Cuál era la pregunta?
La
Uh,
empagliflozina.
empagliflozine. It don't has an
Empagliflozina no tiene
indication. It's
indicación,
off label.
es una
Its
indicación
impact in
off-label.
weight loss
Su impacto
is
en perder peso
2,
es 2,
3,
3,
4,
4,
5% depending
5%
on the
dependiendo del
patient.
paciente.
And we've seen
Y hemos visto que
that
los pacientes
they
pierden
lose
peso con
weight with
CGLT2, sí es cierto,
SLT2s,
pero
but
no
it's not
es
an
una
indication.
indicación.
There's some
Hay
plus
unos
between
estudios por ahí entre
phentermine and
fentermina y
SLT2s and
CGLT2,
some
unas combinaciones que
combinations that are
todavía
still
yo
very
le digo son muy
experimental. They're
experimentales
not for
porque
losing
no son
weight,
para perder
but I
peso,
consider that I
pero
have a type
considero
2
que
diabetic
si tengo
patient
un
where I
diabético
don't
tipo
want
2 que
them
no
to
quiero
gain
ganar
weight.
peso, es
It
una
would
buena
be a good
indicación dar
indication
un
to give
CGLT2 SLT2
que estos
for
pacientes se
glycemic
controlen la
control,
glicemia, que haya
cardiovascular
beneficio
benefit,
cardiovascular y
and
que
not
también
gain weight. I think
no
it's
ganen
interesting
peso.
to
Yo
see
creo que es
the
interesante ver
indication
la
of
indicación tal
empagliflozin.
cual de empaglifosina.
Well, on behalf of
Bueno, a
Feline,
nombre de
we would like
Feline,
to thank our speakers,
agradecemos a nuestros
Dr.
conferencistas,
Manrique, Dr.
doctor
Forero,
Manrique, doctor Forero,
and of
por
course,
supuesto a todos
all
los
the
que se
attendees,
conectaron,
especially
sobre todo
on a
este sábado,
Saturday.
y sus
Interesting questions, and
interesantes
I leave
preguntas,
you
y los dejo
with
con
Dr. Imperia
la doctora
for
Imperia
closing and
ya para el
for the
cierre de
farewell.
despedida.
I would like to
Los
invite you to
invitamos
our
a
next
nuestro
webinar
siguiente
for
webinar
October
para el
26th
26
with
de
the topic
octubre con el
New
tema Nuevas
Treatments in
Terapéuticas en
Acromegalia
Acromegalia, a cargo de
by
la
Dr.
doctora
Mayela
María
Gil from
Lourdes
Argentina,
de
coordinated by
Argentina,
Dr. Miguel
coordinado por el
Vasquez
doctor
from
Miguel
Bolivia
Vázquez
and
desde
Dr.
Bolivia
Lanit
y la
Bolvich
doctora
from
Danilovich desde
Argentina.
Argentina.
An
Excelente
excellent
fin de
weekend
semana
to
para
all,
todos y los
and
vemos
thank you
en
for your
breve. Muchas
attention.
gracias por su atención
And thanks to the
y
speakers
gracias a
for
los
your
conferencistas de
excellence.
su excelencia.
Thank you.
A ustedes, gracias.
Delighted. Thank you, everyone.
Muchas gracias a todos.
Thank you.
Gracias a todos.
Gracias a todos.